there. So, all right, everyone. So as everybody is starting to tune in, I want to thank you all for joining, and mostly I want to thank Dr. Rozental. As many of you know, she's one of the sort of the pioneers and sort of up and coming and sort of already established stars in our field. She is the stuff she's done both from a research standpoint and just for the field of hand surgery is incredible. I was lucky enough actually to work with her at JHS Go when she first started it, and was persistent / smart enough to actually get it on PubMed, which was no small task, I have to say. I have to say, Tamara, since you've done that, I've actually reached out to a couple of people like those invitations, and they've already accepted it. So it's like I feel like that was like the magic button that you were able to get that by. So that was huge. But anyways, nonetheless, thank you very much for joining us, and I really appreciate you taking the time, and the floor is yours.
Excellent. Well, it's great. It's great to be here, even if it's virtual, and it's nice to see so many familiar faces and names. So that's cool. And thanks also for all of your help and contributions to JHS Go, because it's been a big part of making it a success. So no longer mine, but keep it coming. So I was going to talk to you guys tonight a little bit about ulnar side wrist pain, just to do something different. And I tried to do a talk that is fairly kind of pragmatic and just offer some technical tips and algorithms as to how I tend to think about these things. Then we can talk at your leisure. So let me see if I can successfully screen share here. You guys see that okay?
Yep.
Advancing?
Yep.
Cool. Okay. So I was going to talk a little bit about ulnar impaction and DRUJ arthritis as a combo. So the way I tend to think about ulnar impaction is as a progression. So it starts off with impaction. Usually you end up with a TFCC central tear. Subsequently, you'll get chondral lesions in the lunator triquetrum. You can get lunar-triquetral instability. And over time, you may get some midcarpal changes, particularly in the hamate. And in that continuum is kind of how I think about how we're going to treat this. So there's two major categories of ulnar impaction to think about. One is congenital, and the other one is a result of distal radius malunion, or at least those are the two most common. They're probably not the only ones. And people typically on physical exam will have some pain dorsally over the lunate, and they'll have pain with load bearing and with rotation. You can do an ulnar grind test, which may be positive, and then I always like to check for DRUJ stability because that may alter what I end up doing with these patients. On the imaging front, typically you want to try and get a PA and a lateral with the shoulder abducted at 90 and the elbow abducted and the elbow at 90, and that's kind of the traditional textbook way. I think in reality in clinic, it's pretty hard to get that unless you specifically request it. If you're worried about dynamic injury, then clenched fist views can be helpful. And this I do insist on is trying to get pictures of the contralateral wrist, because that, some people just have congenital ulnar positive variants on both sides. They've been that way for a very long time. And then if you do get advanced imaging in MRI, what you're looking for is edema on the ulnar corner of the lunate, and in an ideal sort of classic case, you'll also get some edema in the ulna, and that's what helps you differentiate it from Kienbach's disease. So this is sort of what the classic thing will look like. You'll see cystic changes in the lunate right there, and then on MRI, you'll see some edema, you'll see thinning of the TFCC, which you can see in the arrows here, and in this particular MRI, there's no changes in the lunate, but sometimes you'll get a kissing lesion on the lunate as well. In terms of the treatment algorithm, so the way I like to think about it is, number one, is there ulnar positive variance? Number two, is there a distal radius malunion I need to consider? And then number three, what does the DRUJ look like? Is it unstable? Is there impingement? Is there arthritis? And what kind of DRUJ do they have? So I don't know how many of you are familiar with the classifications of DRUJ anatomy, and there's a couple, but this one, which is a Tolat one, which I depicted here, you can see that if you have a type C, for instance, where the DRUJ is kind of tilted towards the radius, if you shorten the ulna, you may actually make a problem worse because you'll get more impingement. So it's just good to kind of keep that in mind as you start to think about how you're going to treat this. So for the congenital cases, there's a couple different options. One is to do an arthroscopic wafer, and the indications for this, you kind of already need to have a TFCC tear because you're going to make a big hole in the TFC to put the burr through it. So you wouldn't want to do this in a patient who has an intact TFCC. Typically, according to literature, it kind of works best if you have 3 millimeters of variance or less, because otherwise it's just hard to take a big chunk of bone. And it works well in people who are elderly or lower demand. I have to admit, I'm not a huge big fan of this operation. I very rarely do it, but it's good to know that it's an option. And I'm curious to hear later whether it's something that you all use. The ulnar shortening osteotomy, which is probably the workhorse for this, you can do if the TFCC is intact, or if it's torn. It's good for large amounts of ulnar positive variance. I think it gets harder after about 1 centimeter. It gets a little bit more challenging, but it's certainly possible. And it works well if you have a congruent DRUJ. In terms of the surgical technique, you can use transverse, oblique, or step cut osteotomies. Most of us at this point use compression plates that help you obtain a good reduction and compression across your osteotomy site. I like to put the plate volarly so that I don't have to take it out later because of hardware irritation. And there's always a question of should you also do a TFCC debridement, because the MRIs will almost always have a read for TFCC injury. And people feel differently about that. I'll kind of go over what the literature shows. But I know there's some surgeons who feel very strongly that you should scope and debride the TFCC, and others who don't. I think the complications for ulnar shortening osteotomy are real. So non-union, if you look at the reported stuff out there, it's about 17%, and the other is hardware irritation. I think the hardware irritation you can minimize by how you position the plate. The non-union is a little bit harder. So, this is a case I did as a gent who had radiocarpal arthritis and also ulnar positive variance. So I kind of took this in stepwise fashion. I shortened his ulna, and I was super happy with the way it looked. But then those x-rays are, 9 months later, where he still hasn't healed the osteotomy. Despite the fact that I feel like I got good compression and I was happy with how the procedure went. And so in this particular case, I had to go back anyway to do a radiocarpal fusion. And so I just bone grafted his osteotomy site, and he went on to heal eventually. But that's a real thing. And it's not the only case that I've had or that other folks have had with non-unions. In the cases of distal radius, so it's a little bit different, because your options are to do an ulnar shortening or to do a radial lengthening. And for me, that really depends on what the anatomy of the malunion is. If you've got a case which is purely just shortening and there's no angulation deformity, so it's just coronal plane, I think that's a good case for a ulnar shortening. If, on the other hand, you have something like this, where you have a significantly shortened distal radius, but there's also an angular deformity that you want to address, you're probably better off doing a radial lengthening, because then you can do both things at once. It's definitely harder to do, but I think it's the right thing to do if you also have to correct angulation. In this particular case, I used a big chunk of iliac bone crest graft after he had non-united the first attempt at fixing it. So then in terms of the DRUJ, so we'll have to assess if it's unstable or not. I think if it is unstable, it's a good argument to do a TFCC repair. And then if patients have arthritis, you can either do a Sava-Kapandji arthrodesis or an SK, or just resect the ulnar head. And I'll talk a little bit about that in the last few slides of the talk. So this is, classic case of DRUJ instability or arthritis. So they're ulnar positive and they also have arthritis. So to me, this is a great indication for an SK, because you can do your osteotomy and shorten the ulna and put it where you want it, and then fuse across the osteotomy site, and then you can kind of revise the ulnar osteotomy if you need to make it a little bit shorter, if you need to take more bone. But it allows you to correct 2 problems in one go. So I think this is a pretty nice indication in a younger patient for this procedure. So other things to just think about. So tips in the hamate can get lesions there, which is an extension of the impaction force. And some folks debride that arthroscopically. It's not really clear if that's important or not. So no great data on that. And then styloid impaction, which is a little bit of a different animal, in which case you have a very big styloid, which is impacting on the triquetrum when people extend and supinate the wrist. Usually you see this if the styloid is bigger than 6 millimeters, and you can get kissing lesions between the triquetrum and the styloid, which you can appreciate on an MRI. And this you can treat with more simply just doing an ulnar styloidectomy, which you can do either open or arthroscopic and preserve the TFCC. So it's a bit of a different animal. So just to review what's out there in terms of outcomes, there's not a ton of studies, but there's a few recent ones that I think are worth talking about. So this one was published last year. So it's 100 patients who had ulnar shortening osteotomies, and about half of them had a distal radius and half of them were congenital. And they found that the outcome scores improved regardless of etiology, and they improved similarly. Grip strength also improved. So you can see the two columns on the right in the graph, so idiopathic versus DRF, and they look really similar. They had a pretty significant complication rate of 64%. 32% of those were hard removal and 6% were non-union. So the two things I talked about earlier that I think are real and that we have to consider. This study looked at specifically patients with distal radius fractures, and they compared doing ulnar shortenings versus radial lengthenings. Both groups really improved quite significantly with VAS scores that were very low. The DASH scores were low as well, but they were better in the radial lengthening, and they found more complications with the ulnar shortening osteotomies. And then just looking at the question of DRUJ anatomy as well as TFCC. So in 29 patients who had the 3 different types of DRUJs that I showed earlier, they all seem to get better. This is, again, it's a small series, but it didn't seem that the DRUJ morphology really had much of an impact on their results. The smaller study at the bottom in arthroscopy compared a wafer versus ulnar shortening, and they found that the wafer did better at 3 months, but at a year they were about the same. And as you would expect, the complications were greater in an ulnar shortening osteotomy. And lastly, this one specifically looking at TFCC, so 27 wrists, they compared ulnar shortening alone versus debridement plus ulnar shortening versus debridement by themselves. They didn't find many differences. They all improved, but many of the patients who just went DFCC debridement by itself without the ulnar shortening had persistent symptoms. So, when you put it all together, it makes a good argument that you should definitely do something about the ulna, and what you do about the TFCC kind of depends on your level of patience and resources and desire to spend an additional hour in the OR. This one also, so central tears and some with foveal injury, and they performed scopes in all of them, and they only repaired the TFCC if the DRUJ was unstable, and the effect of a TFCC injury really did not influence outcome. So this has led me to kind of stop scoping them unless they're grossly unstable. So this is what my algorithm looks like at this point. So if they're congenital and it's under 3 millimeters, I'll consider a wafer, although I'm more likely to do an ulnar shortening. You can do a radial lengthening if you want to as well. If they're over 3 millimeters, I'll go directly to an ulnar shortening. If it's a distal radius, I'll do a radial shortening with, if the radius is short but there's no angular deformity, I'll just go for ulnar shortening. If they're angled, I prefer to do a radial lengthening. And then if they have arthritis, it's an SK or a DARA. I prefer the SK in younger, more active patients. And if they have instability, a TFCC repair. So that's sort of the basics in terms of ulnocarpal impaction. I can kind of move to the salvage stuff a little bit maybe, and then I'll take some questions at the end. So in terms of when they're arthritic, talked a little bit about the DARA and an SK. The other option is a hemiresection. So when I was a fellow at the Brigham, this was the most popular option. I think, for me, it's fallen a little bit out of favor because people, although you think it's kind of ideal in that you're only taking away half the ulna and you're maintaining the TFCC, a lot of patients do have symptomatic impingement. So in my hands, it's either a DARA or an SK. The SK is by far my favorite, so I do quite a number of these, and this is just reviewing some of the literature that's out there. A lot of the studies come out of Japan. There's a couple of others. So the first one is 100 patients, pretty good scores in terms of pain relief. A lot of patients have radiographic impingement, but the key thing to note is that it's rarely symptomatic. In Agaki's series, which was kind of the first bigger series, 50% of them had some instability of the proximal stump, and 74% also had some radiographic impingement. The bottom series is ours. So we, a little bit later in the game, we had some actual patient-reported outcomes, and we found that the DASH scores, the quick DASH scores, really improved pretty significantly from 52 to 28. In this series, we had 20% complications. Most were hard removal. We really didn't have any issues with non-unions or instability that required revision. And I think the hardware issues are easily addressed with some technical tips, which I can kind of go over. So to do an SK, you can either go through the fifth compartment or ulnarly through the ECU and FCU. I like going dorsally. It makes a decortication of the DRUJ a little bit easier. Placement of the screws is harder. So you have to raise a flap to allow you to get ulnarly, or you can make 2 poke holes and make separate incisions. But either one I think is acceptable. I really like to keep this dissection to a minimum. And one of the key things to avoid instability is when I do the resection at the ulnar head, I really want to do it fairly distal. So at the metaphyseal flare, I don't like to come more proximal. I think you minimize how much instability you get that way. And I take usually a centimeter. I try not to take any more. And after that, you can prepare the DRUJ for fusion. I usually do that with a burr. And instead of using the traditional screws and washers, which is what was used in the initial series, I just use cannulated headless self-drilling, self-tapping screws, which make it really easy. All the screws are buried. I haven't had to take a single one out. And then to prevent bony regrowth and to potentially add with some stability, I just put the pronator as interposed material through a couple of drill holes in the proximal ulnar stump. I know other surgeons sometimes use FCU or ECU, which are also pretty reasonable options. And then I immobilize them usually for 6 weeks in a sugar tongue before letting them rehab. And I tell most of my folks that it's going to be about a year before they learn to like this, but you know, they do well, and there's rare people who need to revise for other reasons. So this is kind of what it looks like for me. So these are headless compression screws. I use Osteomed, but I mean, any of them are fine. And you can see my cut in the ulna is really fairly distal. It's right at the metaphyseal flare. And I think that's kind of my key point when I do these. DARA also, you know, it's technically easier. You just kind of whack off the head of the ulna. It's less complicated, less technically demanding. Most of the studies have shown good improvements in motion and grip strength. If you compare SKs to DARA, the pain relief tends to be better in SK. Instability, they both complain of it, but it seems to be less of an issue in the SK by a little bit. So I think in older patients, a DARA, and especially in rheumatoid patients, it's a good option. You want to try and keep the resection subperiosteal and make it proximal to the sigmoid notch. I usually imbricate a periosteal sleeve to the TFCC and the ECU to try and maintain some of those soft tissue attachments. Some people add ECU, FCU. I usually don't. And I think one key point for DARA is if the patients have ulnocarpal translation and their carpus is going ulnarly, you probably want to do an SK to give them some stability, because otherwise it's going to make that worse. So who do I use this in? Older low demand patients, rheumatoid patients, and patients like this one where I have to do some other type of fusion, and it's just a lot to ask to do a radioscapholunate fusion and also do an SK, although I've done it. This is a little bit easier. And again, you know, don't take too much ulna, because that's when you get into trouble with proximal instability. Ulnar head arthroplasty, so not something I have a big experience with at all, but you know, there's definitely studies out there. The short-term outcomes, so the first 2 studies, you know, are relatively small series at a couple of years outcomes, and everybody seems to get better in terms of pain and grip strength. And in short term, there doesn't seem to be much implant failure. Once you start to get into studies that have looked at longer term, so this one out of Mayo, 47 patients, they all do great, but 30% revision rate within the first few years. So that's not insignificant. And that's why my preference is to do an SK as opposed to doing this. I think this is a good option for when the SKs fail, if they fail. And then lastly, DRUJ arthritis, so an ulnar head arthroplasty. So you're actually replacing not just the ulnar head, but the whole DRUJ. It's good to look at the cartilage before you do that. Try and preserve the soft tissue envelope in the TFCC, debriding the sigmoid fossa of any soft tissue. And then you want to try and avoid impaction with a prosthesis that is too large, and usually repair the soft tissues through drill holes in the sigmoid notch. I'm sorry, this is still, I was talking about the ulnar head arthroplasty, not the DRUJ. My bad. So this is kind of what that would look like. The DRUJ arthroplasty, so here this says, I'm sorry, it also improvements in all the studies in terms of pain and grip strength. short-term studies at 2 years, no loosening or failure. Once you get to a little bit longer, the more recent studies are also showing increased complications, so 40-some% complications, 24% reoperations. So that's important to think about. Similarly, you want to kind of create an ulnar-based flap and open the TFCC, but open the ECU, but spare the TFCC. Leaving about 3 millimeters of the sigmoid notch distal to the plate. And when you're looking at the amount of ulnar resection, it's best to do that in pronation. And usually people will place a fascial flap between the prosthesis and the ECU. I think the important thing to note with these is that most of these patients is not their first go around, and they've usually had multiple surgeries, and just be careful with prior soft tissue loss from other procedures, because that'll affect your ability to get it closed and risk of infection and future issues. So that's what this looks like post-op. You can see the dissection is fairly extensive in terms of stripping all of the tissues off the radius and ulna. So really soft tissue complications seem to be a bigger deal than the bony complications, at least in most of the published series. And that's it. That's my whirlwind through this. And I'm happy to talk about it, talk about cases, answer any questions.
Fantastic. I appreciate that. That's great. Really nice overview. Does anybody have questions before we dive into stuff? So let's see, where's our fellows? So Chrissy or Spencer?
Thank you so much. I do have a question. My question was about, you said that the patients after SKs, they take like a year before they learn to like it. So what are they complaining to you about the most in that first year? And like after that, do you feel like those things go away, or they just learn to live with it?
I think it's a little bit of both. I think the main issue is the instability of the stump, of the proximal stump, which is usually not gross instability. It just occurs in certain motions. And usually it's with supination, holding a weight and supination, that they'll feel it pop a little bit. And I think as they regain their strength and some of the muscle bulk, that gets better. Does it completely go away? Probably not. But another indication that I use that operation for is Madelung's, and those are typically young patients, and they do fine with it. They do great. They all get back to doing everything. It just takes them a little bit of time to get used to it.
Awesome, thanks.
I just had a question regarding rheumatoid patients specifically. Do you have any different thoughts on the treatment of them in terms of how you approach DRUJ pathology?
For me, it's more about age than it is about the etiology. So age and demand. So I still prefer an SK in a rheumatoid who's young. And I've done it, the typical thing, for instance, when you're fusing a wrist, people often just do a DERA to address a DRUJ. But if it's a 20-year-old or a 30-year-old, and I know that that's more rare, but I do get some who come into the office, I still prefer to do an SK because I think they get better support and they get less ulnar-sided symptoms. Older patients, lower demand, do a DERA.
Thank you.
So Spencer, one thing to keep in mind, right, for the RA patients is that oftentimes their autoimmune has eroded away a lot of their synovium and or the ligaments, and so they have ulnar translocation of their carpus. So you can't just do a DRA, right? So you have to do an SK or something similar to that.
Right. Less of an issue, of course, if you're fusing their wrist as well.
Yeah.
Yes. Typically, if you're doing the wrist fusion, then you don't have to worry about it.
You don't have to worry about it. Exactly.
Yeah. No. I like that you're a proponent of the SKs. I feel like sometimes, especially here, I'm
kind of rare. I realize that.
I'm on an island a bit. So because I like them better. I think that especially for active people, you maintain the ulnar side of the wrist. I think. I don't really have seen, I don't have the experience you do, but I haven't seen the stump instability, and I don't know. Anyways, so generally I really like them. Maybe do you want to expand upon, there's a classic debate and I was even told at the IFSSH in a panel that SKs are completely outdated and that the person can't believe that people are still doing that. Do you want to expand upon your why you prefer them for more active people versus DERAs, and what are the considerations you kind of have when deciding between the two?
Sure. So I realize that they're popular in Japan. When I talk about this in Japan, they get really excited, like, oh, yeah. Look, nobody in the US who does this. I think the bias in the States is not so much SK versus DARA, it's SK versus arthroplasty.
Sure.
Because I think the indications for DARA tend to be older patients. So for me, SK is, you know, the younger active people in whom I don't want to do a DARA. And I think, you know, why do I like the SK? Because it's one and done. And the complication rate is really low. And, you know, if 30%, so say you use big screws and washers and your complication rate's a hard removal, no big deal. An infection or an ulnar head that loosens, you know, resorption around what remains of the ulna that you then have to revise, like those are big problems. If you get a bunch of resorption around an ulnar head arthroplasty, and then you have a lot more proximal stump instability when there's only half of an ulna left, and there are no good solutions to that.
Yeah.
So, you know, I'm kind of a simple-minded person. I like simple solutions. I don't like to do revision surgery if I can help it. So I think that's why.
Yeah.
And so, you know, I've been in practice for 18 years. I've done that series I published was 57. Those were most of them were mine, but there were others that came to me from elsewhere. I've added a few since that was published. I think I've had to revise one for instability that was really very symptomatic. And I ended up doing, I don't know if you're familiar with the Sotorianos, basically sort of anchovy of just putting allograft around the proximal ulnar stump, and that actually worked really well. And that seemed to do fine. So, you know, that's a 1 out of probably 70 that I've had an issue with enough that required revision.
Awesome. And then you touched on this, but maybe so I guess I'd be curious your commentary on hemiresection. So maybe, you know, the lesser DARA that some people kind of refer to.
So, you know, I trained with Barry Simmons at the Brigham, and that's what he would do on all his rheumatoids. But he was really the only one. And I think what happens with the hemiresection is it looks really cool in a diagram when you look at it in a schematic, like, oh, this makes total sense. But when the wrist rotates, you'll end up with a portion of the ulnar head still coming in contact with the sigmoid notch. So you don't eliminate all of the problem, and you add a little bit of instability and they still have pain.
Yeah.
So that just, I think, has fallen out of favor for that reason.
Yeah.
Like in a low demand person, maybe fine.
Yeah.
I mean, I'm assuming at Mayo, it was mostly arthroplasty.
Actually, you know, it was it was a little bit of everything. Because they had rheumatoid, so there was DARAs, and they kind of did more of a hemiresection than true DARA. There was, you know, 1 or 2 doing arthroplasties. Dr. Marco was doing a lot of arthroplasties when he could, when in non-rheumatoids. And then, but no, like I did a couple of SKs with Alan Bishop and Steve Moran. So, I mean, there's still kind of a nice mix. So.
I just had another question. Do you feel like there's any role for this like ulnar-sided denervations? Like I know like AIN, PIN is pretty popular, but like, do you consider doing that in these patients?
There's definitely a role. Interestingly, I find myself doing it less than I used to. And I think it depends on your indication. I mean, I think if they have instability, that's probably not going to be enough. If it's chronic pain from some arthritis or something more subtle, I think it's a reasonable thing to consider. I honestly don't know how successful a purely ulnar-sided denervation is going to be.
Alan Peltovich, I was going to say Peltovich is on. I believe he's a big proponent of that. Alan, you do a fair number of the ulnar-sided denervations, don't you?
I've done 2. I've done 2, both for people who've had failed other procedures, and I have Tamara, first of all, thank you. That was a great talk, by the way. But I like you don't really do the arthroplasty. So for me, if nothing else is working, then a denervation. I've done it in that circumstance, and I've really been so far very enthusiastic about it. So I'm a believer in denervation. I do like that operation. I think your point about instability is 100% valid, because that's not going to solve that. But you know, my N = 2 so far is doing really well.
And Alan, are you doing AIN, PIN, or are you doing the denervation off of the SBU and branches?
No, everything. So ulnar nerve,
Yeah.
posterior branch, the AIN, the PIN, and there's even a sometimes a contribution from I can't remember if it's the posterior antebrachial cutaneous nerve that runs along the ECU compartment. So I'm killing everything that's there. I think. I mean, I'm not leaving anything behind.
Incisions or 3?
One incision.
One incision. Okay.
And when I've done a wrist denervation, it's the same thing. I don't actually really have much faith that doing a PIN neurectomy alone when we do wrist operations actually does anything. I mean, I don't think it really contributes that much to pain relief. And AIN, PIN at best is only going to get the central part of the wrist, radiolunate articulation. So if you're looking for relief in other parts of the wrist, just doing AIN, PIN is not going to be enough.
I'll have to try it. So what do you do for patients with symptomatic Madelung's? Like, what's your operation of choice?
A radial osteotomy.
Okay.
But I'm treating them when they're teenagers and
No, I mean adults.
Then it depends on deformity. If they still have a decent distal radial deformity, then I do a radial osteotomy. If they have only very mild deformity, then usually the problem is ulnocarpal impaction, then I'll do an ulnar shortening. But when it's more severe, the ulna looks taller on a PA, but it's not really articulating with the carpus at all. So I don't think the pain comes from the ulna as much as like a uncovered lunate. And so so when I've done the radial osteotomy, I've been happy with those results.
Because I've tend to treated them with, so I only see them as older adults.
Yeah.
And I'll do ulnar shortenings unless their DRUJ I feel is really unstable, and then I'll do an SK.
No, that's exactly right. I mean,
but that was kind of an indication for an SK that I didn't encounter too much in training.
I
just kind of started doing that.
I do like that operation too. I don't know if anybody else has done them, but I like the swathophalangy. I do like it.
We used to do all Bowers resections here, interestingly enough. But it was, they're very technically demanding, as you mentioned, right? What we used to do is you used to have to put your finger in the resection and then rotate the wrist to make sure that it wasn't going to pinch your finger as it rotates, because you're 100% correct. You almost always have to take off a lot more than what you think to prevent the rotation causing the impingement, and then getting the dorsal capsule interposed to actually prevent the impingement was also an issue. So it's a technically challenging. I think it's actually harder than the other two, interestingly enough.
I agree.
To get it just right.
I mean, the thing with the SKs, if you don't have to shorten the ulna at all, if you're just dealing with the regular DRUJ arthritis, the way I like to do them to make them simple is I'll actually decorticate it, throw my screws in, and then do the osteotomy later. Because then everything's lined up. You don't have to really focus too much on whether it's properly aligned. Obviously, if you have to shorten them, then that doesn't work, and you have to do the osteotomy first and then bring them to where you want it to be and then put the screws across. But to me, the technical challenge in the SKs is almost always just getting the screws in the right position and ending up with the ulnar head reduced the way you want it to be and not tilted dorsally or volarly.
Yeah, no, I think so. Yeah, and the screws though, I agree, is nice, and you almost have it's almost impossible to have hardware issues when you have these buried compression screws. So
yeah, as long as you don't put them through the ECU, you're usually so.
And you said you don't do a stump, so I always do like a little ECU kind of FCU split. You don't do anything. You don't do any of that, like the Bring Jupiter modifications of that to stabilize.
She said PQ only if you were listening.
Yeah, I don't. So I just put 2 little drill holes with a K-wire in the proximal ulna, and I just kind of put the PQ over the stump and suck it down volarly a little bit. And mostly it kind of, I hope it prevents reossification, and maybe it scars it down a little bit.
That's awesome.
But I mean, I've done this on some fairly high demand people, laborers, surgeons, etc.
Awesome. For those interested, I put an article on what Tamara just said, but it correlates the amount of ulnar resection with ulnar stump instability. with catastrophic hemangies. So it's basically exactly what she said, but to minimize how much you take. So it's in the chat. So why don't we go through some cases? Because so Chrissy and Spencer are two fellows, and then John is one of the Rozental on hand right now. And so why don't we go through some cases, and we can sort of go through chat about them, and maybe it'll stimulate some more conversation. So I don't know, Chrissy or Spencer, do you have one that you want to go first?
Yeah, I can go.
You should be enabled to share your screen.
Can you see that?
Yes.
All right, cool. All right. So this patient is a 32-year-old right-hand dominant female, was coming in with left-sided wrist pain that that started after a car accident 3 months prior. She had done 2 months of wrist immobilization and a brace and some hand therapy. Was initially saying she had 5 out of 10 pain, localized to the dorsal wrist, worse with wrist extension and lifting. No significant past medical history or surgical history, and she is a non-smoker. On her exam, and I have a video of it as well. And the next slide, she had tenderness to palpation over the DRUJ, no real significant foveal tenderness, and then greater mobility of the ulna with piano key maneuver on the left compared to the right. Her range of motion, just based on the notes, was similar between the two sides. And I'm sorry, I didn't write this here, but they said 70 degrees of pronosupination on the left, and they didn't say what it was on the right. So this is Dr. Wagner examining this patient. Let's pretend it's not in pre-op.
Just really liking that.
She loves it.
It hurts. See how much pain she is. And you can see here how she just sits dislocated. And I can push her back in and toss right back. Push her back in, toss her back. Push back in. Push back. You can see here. You can see the shoes. Here, let me go with this. She stays up. She stays on.
Sorry, Dr. Wagner, I'm making it look like you like torture people.
He does.
It seems like foveal tenderness there. Yeah.
It's just push her on the hand.
You probably move to the next one if you want.
Okay. Yeah, I am. I'm trying. My computer's like freezing. It's very old. Oh God. Okay. So I didn't mean to do that. So I guess like at this point, like what like further workup would you do for this person who has like frank instability? And I do have the x-rays there following that MRI, but hold on, let me. Like, would you always get an MRI for these people? Do you typically get like a CT scan to make sure that they don't have DRUJ arthritis, or is like the x-ray enough?
I mean, I think the x-ray obviously shows you that they have ulnar positive variants, and that's helpful, but the reason why they're unstable, assuming they weren't unstable before their injury, is still not entirely clear. So I usually would want to get an MRI just to see what the story with the TFCC is, because if that's the source of the instability, then that's a different fix in my book.
Sorry, my kids are trying to like break into my room. Hold on. Okay, so I have some videos of the MRI. Sorry. So this one you could just see the like dorsal subluxation of the ulna, which I thought was interesting. And then in this next one, the coronal, and then she did have some enhancement over the ulnar aspect of her lunate there too. They read it as like an intrasubstance tear, but like no like other like peripheral or central tear. And then like obviously we're seeing concern for foveal tear given her like frank like subluxation. And I thought this was an interesting view of things as well. You can see it's like not congruent there.
Okay.
So at this point, she's had 2 months of, non-operative management with wrist brace and hand therapy, not improving. Would like any other imaging that you would get, would you like do any more non-operative management for her? Or would you offer her surgery? Like, I know some people say, if you have gross instability, then like no amount of like real therapy is going to improve that. But what do you typically do?
So I don't know that you need additional imaging. I mean, some people will get CT scans and compare it to the contralateral side, but I think you have a pretty clear idea of what the issue is, but it's just based on what you have. So I'm not sure that's super necessary. I would probably start to think about surgery with her. I don't know how much more strength you can add to this to make it better.
And to add to a little bit to history, and Christy, sorry, the notes aren't the best. She actually was having wrist pain, ulnar side wrist pain before the accident as well. Was being treated for it, had an injection for it, whatnot. But we didn't have much workup in that way. Been treated outside. I didn't have much like X-rays, so I didn't have anything to compare it to. So there is some vague history of ulnar side wrist pain before the accident, but it got worse after the accident. So it's hard to say, but it does seem like it's been going on for a bit of time.
They did get bilateral CT scans and showed dorsal subluxation of the ulna on the left, different compared to the right, and then like no significant arthritis or anything like that. So like this was one of the questions that I had really is like, at what point, I think a lot of times these patients come in with very vague histories, don't really know how long their pain's been going on for. Like, at what point are you talking to them about potentially doing a TFCC repair versus like planning to do a reconstruction like a Berger Adams or something like that?
Yeah, so this is a tough case, but it comes up. So I feel like we've all seen this case, and so I think that the thought process for me is, do I think it's TFCC? And if your TFCC looks pretty well attached, it's unlikely that that's the only reason, but I would want to make sure of that. Number two, do you think that if you shorten her ulna, you're going to get rid of that instability? Is that the only thing that you need to address? Given how much instability she has, I'm skeptical that an ulnar shortening is going to be enough. So then you got to think about, well, do I just do an ulnar shortening and reconstruct it with a soft tissue procedure, which you can do, but that's a lot of surgery. I think it also depends if you're a fan of the Adams reconstruction or you're not. I fall in the not side. Why? I just think they stretch out over time, and I just don't know that I think it's a big dissection, and I'm not sure they have good long-term outcomes. So, and then you're back to the SK as one thing that you could do, which is a little hard to do in a young person with a DRUJ that's not arthritic, but you can shorten her and you can fix the instability, and it's going to work. So I would lean in that direction unless there was a clear TFC injury that I could fix and pin.
Awesome. That's a great point. So we ended up doing this arthroscopic assisted TFCC reconstruction similar to what's described by PC Ho. And then I just have some videos of kind of what our diagnostic arthroscopy. Unfortunately, sorry, I'm not as good at like splicing the videos together as Dr. Wagner is. So I have like the arthroscopic side of things, and then I have some videos of kind of the gross appearance of like what we were doing on the outside. So this is just, we were starting out and I sped it up to make us look really fast and awesome. Just doing looking at the TFCC, and there was this split tear here centrally that we were debriding. Didn't make it fast enough. Trampoline test. Do a hook test here that shows it's really like very loose there, not really attached underneath. So we were concerned for like foveal tear at this point. And then this is just us continuing to try and decide. So what we were trying to decide here was, is the tissue like, is this something that we could repair, or like, would it be hardy enough for us to be able to do a repair, or did we need to do a reconstruction? And we felt like after examining this tissue that it didn't seem like it would be a sturdy enough repair, so we planned to do a reconstruction. Sorry, my computer hates this experience. So I'm just gonna like fast forward this to the end. Well, this is like the mattress suture that we placed in the TFCC, and then we reinforced this with a palmaris graft. So just show this real quickly. And make it fast enough. So we drilled through the ulna with the K-wire, and then we over drilled that with the drill, and then we used that needle to bring in a looped PDS, and then we're able to pull this fiber wire through for a horizontal mattress stitch. And then I'll go through what we did, but this is the kind of the end result arthroscopically. So we drilled a hole in the ulnar aspect of the distal radius, and then brought our palmaris graft through that, and then brought it through the dorsal capsule and the volar capsule, and then brought it out through our bone tunnel. Let me see if pull the rest of it through in a second, and then it'll be. This is us pulling on the palmaris graft there.
And you used the same, I'm assuming you used the same tunnel for your original foveal
That's right.
thing as well. So you pulled it all through the same hole, which makes sense.
No,
Okay.
the original suture, that horizontal mattress suture, we like put it through that hole, but a different spot in the TFCC itself. But yeah, you're right. Everything was like coming out through that same hole, and then we used push anchors to put it into the more proximal aspect of the ulna. So this was just the shot from intraoperatively to show like where we drilled into the ulna for our sutures, and then you can see here the drill hole that goes through the distal radius that we put the graft through. And this is, I promise, quick. Just putting the graft from dorsal to volar.
And you use the little Arthrex passer, which is nice.
Yeah.
I gotcha.
And then we brought it back out so that both ends of our graft were dorsal. So Dr. Wagner used a grasper, and I fed him the graft from the volar side. He brought them both to the dorsal aspect. And then he used is it a Houston suture passer, Dr. Wagner, or tendon passer, sorry, that you put back through the bone tunnel, brought out, and then again, use that Arthrex tendon passer to pass both ends of the graft out through that.
Yeah. The Arthrex bone passer, if you haven't used it, it's pretty nice for this. If you're trying to get like a bunch through a small hole, Tamara,
Yeah.
it's a really cool thing. I hadn't seen it before. I think Scott Wolf, gosh, you saw Scott Wolf use it, but it's ever since
Scott,
really nice.
Yeah, Scott's the one who put me on this. After I was talking to him about doing his anafad, I was like, how in the world are you passing the tendon so easily every time? And this is it. It only comes in one size. Well, that's not true. This is the smallest of the sizes, I should say.
Look how fast they made us look. And then this is kind of funny, but we had Spencer test the DRUJ at the end, and you can't see the wrist.
Yeah, because
It looks awesome.
It felt so sturdy. I can't even put it in.
Rock solid.
Yeah, that's all I have. But thank you again for giving us your talk. I loved it.
So Tamara, so there's a couple things on that. One, the X-ray looked like it was long, but then on the CT and the MRI, that it wasn't. It seemed like it was short. So I wasn't sure if I should shorten that one. Maybe you should always shorten them, even if you're questioning. So that's why we didn't shorten. I'd be curious to see your thoughts on a situation like that. And the second thing,
based on that fluoro, I wouldn't either.
yeah, and then the second thing, so deciding, we talked about this today because we actually had a TFCC that I was potentially going to reconstruct, and then we decided to repair it today. I feel like that's a hard decision. My complete unscientific way of doing it is I don't know if Chrissy could show you or saw it, but I take a probe, and if I can stick the probe through the meat of the TFCC and it actually pierces the actual meat of the tissue, I feel like that's like probably not good enough tissue to truly stabilize it. And so if like the little blunt probe can pierce the meat, then I think like I'll repair it, but then I'll add a graft. Do you have a way of determining what's a repairable TFCC?
No, I mean, not a very scientific way either. I have moved from doing my TFC repairs arthroscopically to doing them mini open. So, I'll scope it, I'll look at it, I'll poke at it, and then I'll make a small incision, which is about the same size that you end up using to put your anchors or whatever sutures you have anyway.
Sure.
I'll throw 2 fiber loops through it and through a bone tunnel, just like you did, dunk them with a push block or something into the ulna. And I feel like most of the time, if the TFCC is the problem, you can get a pretty solid repair that way. They're really unstable pre-op, maybe I'll put a pin in the DRUJ for a short period of time.
And would you have shortened this? So you said based off of that fluoro, you wouldn't.
Your initial X-rays were hand X-rays. They weren't great wrist X-rays. I think based on that fluoro scan, it doesn't look like she was long. So no, I don't usually. Yeah, like if you shorten them and do a TFC repair, I mean, you can if they're really unstable. That's an option.
Sure.
So Wags, let me ask you this question. I'll play devil's advocate. Why not just try the TFC repair, see how she does, and then come back another day if you need to do a more invasive thing like what you guys did? Why do the palmaris from the get-go? I mean, right here, I would argue that you got, theoretically, it looks like the stitch is holding and you got a foveal repair back. Theoretically, that should hold.
Theoretically, that's the volar side. I felt like the volar side had a little bit. The dorsal side I didn't feel like had much. And that's where you could see the probe, like the probe literally could push through and pull back. So you're right. I got to check. I mean, you could argue, it's like the same debate people have with like the Rozental, right? Just repair it. And if it fails, then do something more later. I guess my mind in this case, in these cases, if I think I can get 2 good mattress sutures in and get a nice repair, then I think I'm okay with it. But if I feel like that it's either going to pull right through or I can't get 2 good mattress sutures, I feel like there's not a lot of downside in harvesting a palmaris. And then sort of doing the reconstruction in addition to having a stitch in the TFCC. In this case, since the probe pulled right through it, I felt like I wanted to back it up with, or I wanted to do. I felt like that it wasn't good enough to hold 2 mattress sutures.
Oh, that's fair. I was just curious as to why I thought one of those.
So what would you do if the TFC was intact? So if you have DRUJ instability and the TFC is intact.
Well, so that's what I was about to ask him as well, because he always gets on me that we should be doing more DRUJ scopes. So I was going to ask him if he actually scoped the DRUJ on this or not.
No, I didn't, because I could tell it was off, and I could tell with it was pretty clear with the hook test and looking through the central tear that was off. But I think, I do scope it. If I get in and I feel like the hook test, trampoline test aren't, but it's instability, I'll stick a 1.9 in the DRUJ and see if the fovea is off. The fovea is still intact and you have instability. Then I'm starting to worry about is like one of the radial ulnar attachments on the radius off. That's right.
So that's my question. Do you do a tendon reconstruction or do you do a bony?
Oh, so if you're saying if it's off the radius?
So TFCC is intact, but your dorsal and volar radial ulnar ligaments are stretched and the patient has DRUJ instability.
Yeah, I do. I don't know. I don't know if that's the right answer, but I had a case of kind of congenitally. It wasn't Madelung, but it was a bit unusual, a bit short, a bit kind of unusual TFCC, and it was obviously stretched and loose. And so we've done that, and then a couple of EDS patients that have really bad DRJ instability. I've done allograft reconstructions. I don't know if that's the right answer. What do you do?
I've gone more to the bony stuff, and I realize that's probably maybe not the board answer and not the textbook answer, because it doesn't necessarily feel right initially to do a DRUJ fusion in somebody who has no arthritis. But I think if they have really bad instability, I just want to make sure it works, and I just want to do one operation.
Yeah, that's a good point.
But those are tough cases.
Yeah, Garib, gotcha. Do y'all have thoughts on this?
I've never scoped a DRUJ. I have not drank the Sanj Kool-Aid yet.
It's not very easy. I do agree. So I'm not sure. It's not something that I do very often.
I don't know that I've ever noticed it, in all honesty, that I've actually ever had a patient that's had specific DRUJ pathology that wasn't related on the ulnar side, or at least I don't know that I've noticed it without the setting of someone with that like an acute distal radius or a prior distal radius that now has
Right.
something like
Well,
that.
that's
And-
usually the case, right? That they have a distal radius and they healed and they're not quite right.
Yeah, that's a much better. I've actually done, well, so we just did one. I did an osteotomy, and the conversation was, I did an osteotomy and a hemiresection, in all honesty. And then the discussion was, do you just do an SK and leave the distal radius alone? But then I'm like, well, look, if you're unhappy, if that doesn't fix the problem, the entire problem, which it wasn't just a supination, pronation issue, it was more than that. Then I was like, well, now you've got an SK in the setting of a malunited distal radius. And I was like, well, that's not an easy solution to fix. I said, look, at least if I can get the radius right first and do a hemiresection, I can always come back. But, you know, we talked about arthroplasty. I put down as a code as an arthroplasty. I couldn't get insurance to approve it, which was interesting. Not that I would have done, it wasn't in my initial plan, but they weren't going to approve it.
You know, the other indication that I've seen kind of float out there are people who've had ulnar pathology, you know, this ulnar fracture treated elsewhere, or some other type of fracture in the forearm where the ulna just healed, slightly malunited, and now they're unstable.
Gotcha. Gotcha. You want to talk about the one we did that's similar to that?
It's easier to do an SK than it is to do.
Which one, Wax?
The malunited mid shaft. It was actually both bones, but that had a DRJ.
Yeah, so you know, so I mean, I know that you've written on it because I think I've seen articles, but we did custom templated osteotomies using one of the 3D companies that, you know, took their forearm on the other side with the CT scan compared to the other one. Was that the one you're talking about?
Yeah.
Yeah. So I mean, we did custom you know, mid shaft osteotomies, and it corrected their DRUJ completely. I was blown away. You know, they had like they're 10 years out from their pediatric growth bone, couldn't fully pronate, supinate from before. And I was like, you know, look, everyone was like, oh, it's your DRUJ. I was like, I don't think it's your DRUJ. I actually think it's your proximal malunion. And sure enough, once we corrected it, they got full motion.
Did you corrected both?
Yeah, we did radius and the ulna. And you know, the problem is like,
there's a pretty young patient.
22, 24 manual labor. The problem is, as you know, most places don't want to do it because they won't cover the cost of the of the 3D of the materialize or whichever one you use to get the guides. But I will tell you, it simplifies the surgery drastically.
Sure, it does.
Tamara, can I ask one question? Do you, when you're doing distal radius osteotomies for the malunions, how are you deciding between a volar plate versus a dorsal plate and graft versus no graft?
So I've moved towards doing it more volar because the operation is just easier. And what I do for graft depends on how much I'm lengthening and what the demands of the patient are. So that one case that I showed, so I did that one twice. I used allograft the first time and then he didn't heal it. And then I put a big chunk of ICBG in there. But usually what I'll do is I'll do a standard volar approach. I'll put my plate down distally. I'll drill a couple of holes, then I'll take it off, then do the osteotomy, and then put the plate back on. And then just by reducing it to the shaft, you'll get your angulation. And then you can just, you know, put the screw in the oblong hole and lengthen it or shorten it as much as you want. If you're going to put a big chunk of graft, you know, it's hard to do that through the volar approach. So most of the time in older patients, when I'm correcting a malunion, you know, 30, 40 degrees of angulation, I just leave it empty. I just pack some bone chips and putty, and they seem to do fine because metaphyseal bone in the radius typically heals pretty well. And the likelihood that the 60 or 70-year-old lady with a distal radius fracture is going to break through the hardware is pretty small. So younger people, more deformity correction, higher demand, I'll put graft.
Okay. And then do you worry about, like, when you're doing too much with the volar, do you ever worry about the extensor tendon, like EPL or something like that? Do you ever like transpose EPL or do you not really buy into that?
I haven't yet. I mean, that one case, I had some big burly fellows that year. We were pulling really hard on that thing. I think they seemed to do okay. Yeah. I think, you know, it's just like doing a PRC in the opposite direction. Everything, the soft tissues kind of readjust and tension. You know, maybe release their carpal tunnel if they have any symptoms. That's probably the only thing I would think about doing. But I think most of the time you can get away without using a big chunk of structural graft. Whereas, you know, traditionally when you did the dorsal osteotomies, that's always what you did because you didn't have the locking technology.
No, absolutely.
The only difference is I may cast them for a few weeks and not let them move immediately.
Makes sense.
I mean, how many of you had a distal radius non-union? It's pretty rare.
Yeah. You're right. See, I feel like most of the ones we see anymore are some of the older patients and yeah, socially young
I'm
patients.
tending to see more on our the few that I've had recently are all related to like these nasty open fractures that we put a dorsal spanning plate on, that are either follow me over from Grady to the Emory side, where it's like, hey, by the way, we start off with some disaster, plated them, maybe overly distracted them to get the tension that we want potentially. Those are the ones that I currently see.
And the few that I've had, have looked like they haven't looked great on X-ray, but they're doing fine clinically, and I just leave those alone. So I think they fill in over time. I had one patient who I was actually very, very worried about because their X-ray looked terrible. They had about a tiny little thing of bridging bone, and the rest was completely ununited. And she was lost to follow-up and came back 3 years later and completely healed the thing. Like you could never tell there was anything there. So I'm not super aggressive on those.
Cool. Paul, Nikki, Amanda, do y'all have anything you want to say, Dr. Rozental, before we sign off?
That was an awesome lecture. Thank you. I can't wait to leave all my distal radius non-unions alone now. Now I have your permission. Perfect.
That was wonderful. Yeah, that was wonderful. Thanks so much for joining us this evening.
No problem. It's fun to do it. Nice to meet all of you. And you guys have to promise me to torture McQuillan appropriately.
We cannot wait. We are very excited about him. We cannot wait. Yeah, we'll have to bring you back when he's here. We'll have to bring you back, or maybe we can bring you in person when he's here.
Deal.
Cool.
All right, guys. So good night.
Nice to see you. Have a good night.
Thank you.